Good afternoon. I'm Dr. John Davison, Chief Executive Officer of the Trust, and I'm glad you're able to join us today for the second webinar in our Business of Practice webinar series titled Guidelines and Pitfalls Regarding Professional Wills and Practice Executors, How to Meet Your Ethical Obligations to Plan for the Unexpected. Presenting today's webinar is Dr. Robin Miller. Dr. Miller is a licensed clinical psychologist and the founder of TheraClosure, Therapist Professional Executor Services. The Trust recently partnered with TheraClosure based on requests from our policyholders wanting more information on creating a clear and actionable emergency plan. TheraClosure can help you create a comprehensive professional will and can serve as your practice executor should you become unable to continue your practice. Informative webinars like this one are just one of the benefits you'll receive as a trust policyholder through this partnership with TheraClosure. We're very pleased to announce a 15% annual discount for trust insureds wishing to sign up for TheraClosure services. Just use the promotion code TRUST15 when you enroll in TheraClosure coverage. We're grateful to TheraClosure for offering this discount, and we are very excited to have Dr. Miller with us today to share her expertise. I hope everyone learns a lot over the next 2 hours. Please join me now in welcoming Dr. Robin Miller.
So you have devoted your professional life to your patients and your practice, but what happens to them if something happens to you? I'm a clinician, and it's a clinical conversation we're going to have today about planning for practice interruptions. As John so kindly introduced me, I am Robin Miller. I do want to disclose a conflict of interest in that I'm involved in TheraClosure, a business that provides therapist professional executor services. It was created in response to doing trainings like these to provide a solution to some of the obstacles that people face that you may know already and that you'll see illustrated as we go along today. So we are starting from the point of the therapeutic bond. What is important here? Why is this important? Well, most of us, I think, no matter our theoretical orientation, hold that the therapeutic alliance is central to healing. It is part of our vehicle of change. But it also can pose risks if it's abruptly severed. Clients may feel abandoned if a therapist suddenly becomes unavailable. Ethical guidelines prohibit abandonment, but sudden emergencies can still cause unintended harm. So what are our responsibilities? We'll talk about the ethics. We have to plan for continuity of care, just in case something were to happen to us. But what is the standard of care for ensuring patient protection and responsible practice transitions? Our code emphasizes do no harm, avoid abandonment, maintain confidentiality, provide responsible referrals. Those seem pretty easy, right? But when we get into how do we do that for each and every one of our practices and our patients in any host of circumstances, this gets pretty tricky. So I think it's really important to look at what we do as therapists. We pride ourselves in being able to tolerate deep emotions, dark emotions, often rage, shame, grief. We go there with our patients, we go there in ourselves to be able to understand how we impact the work. But we don't seem to do that for our own mortality. It's really hard to think about. We're no different than anybody else. And when I meet therapists all the time to talk about this, some people kind of hide their eyes and run the other way, don't want to talk about this subject. But avoidance leads to inadequate planning and leaving clients and loved ones in crisis. So proactive planning is part of our ethical and responsible practice. My closest psychologist, colleague, and friend and supervision partner of 17 years faced a tragic crisis and taught me about courage and grace in the face of dying and the importance of planning. Managing grief notification, practice closure, compassionate client care. These are clinical responsibilities. And serving as a practice executor is not just an administrative duty, but a clinical role. That's one of the most important things I want to convey today. This is a clinical job. So we'll also talk about why our current solutions are inadequate. We get really limited training on professional wills and practice transitions. Online templates are available. Most people go with an informal agreement with a colleague, but they're not enough. They're not clear, they're not comprehensive, they don't provide the information that we really need to have a secure process planned out. And each therapist shouldn't have to figure this out alone. Why isn't there more structured guidance available? If we're required to abide by this ethical duty, we need some help to make it a little bit easier because most of us are not attorneys and we aren't sure where to even begin. I often hear from therapists, I'm young, I'm healthy, I don't need this yet. Or I know I need to do it, but it feels overwhelming. Or I feel really guilty that I haven't made a plan yet. I've been procrastinating for years. Some of you might be resonating to some of these things. They're all so human, but they shouldn't stop us from acting. We have a duty, as we do in all other aspects of our work in providing treatment, to manage our own feelings and to try to do the right thing anyway. So this is not different. So just giving the backdrop, these are the things we're gonna think about. The written emergency plan, a client notification procedures, a confidential record management, transition and referral strategies. We are going to get into the weeds of all of this, and you will hear me because I think plants are an apt analogy. People need to be potted well. They need the right conditions to thrive, and sometimes they need to be repotted. And I'm not known for my subtlety, so you will hear this a few times. So now our slides will move faster. Thank you so much for your willingness to face a tough subject today. We are talking about being prepared, not being paranoid. And we can't prevent loss, but we can talk about preventing traumatic loss. We're talking about due diligence and compassion as extensions of our therapeutic work. So really all of this is about preventing traumatic terminations. What if you, as a therapist in your professional life, what if you suddenly disappeared? I want you to take a moment and jot down what comes to mind. Think of one of your own patients, a high or low functioning person, short-term or long-term patient. What would happen? How would they first encounter that you're not there? How would they feel? What would they do? And then steps from there. What would be impacted? What would your colleagues be faced with? What would your family be left to deal with? What if your own therapist suddenly disappeared? And if you don't have a therapist, imagine what that bond that you've built means to you and what you would feel like if all of a sudden you don't hear from that person. How would you feel? What would you need? The golden rule is a good place to start by imagining what our patients need. And as we all try to, be our best selves, what would help you to feel you had been as compassionate and conscientious in your absence as you try to be as their therapist? So let's start with the ethics. What is our obligation? Where does it come from? We have in our aspirational general principles a few points to guide us. Beneficence, non-maleficence, do no harm, try to do only good. But read carefully. It says in there, psychologists strive to be aware of the possible effect of our own physical and mental health on our ability to help those with whom we work. That's a pretty tall standard that is asked of us. Of course, we can't always be aware, but we can try to be aware. And we are humans, so we need to be aware that life is unpredictable, and that includes for us, not only for our patients. Fidelity and responsibility, we build relationships of trust. And integrity, we try to keep our promises. We don't make unwise commitments. So this is in the backdrop. One patient told me about being in a long-term treatment with an analyst who was very elderly. They had talked about his age and the topic of dying. But when he got ill and missed a couple sessions, the patient got a call from the therapist's daughter saying that he had died. The patient, she said, unexpectedly, she felt really angry and felt that it was selfish of him to practice for so long rather than to give her the opportunity to say goodbye. She said she thinks he kept working because it kept him alive, but now she feels like this was not in the patient's best interest. So when do you stop working? There's no right answer here, but these are questions to be thinking about. What's for you? What's for your patients? What's in the best interest? What are your responsibilities? So according to APA, a psychologist is held to the ethical standard to make reasonable efforts to plan for facilitating services for your client and transfer and protect the confidentiality of records. So reasonable efforts, we are going to come back to that phrase a number of times as well. You'll be tired of that and the plants, both. So we also have our enforceable standards in our ethics code. The interruption of psychological services. We make reasonable efforts to plan for facilitating services in the event that our services are interrupted. Record keeping and fees. Psychologists make plans in advance to facilitate appropriate transfer and to protect the confidentiality of records. And in particular for the interruption of therapy, when entering into a contractual relationship, psychologists make reasonable efforts to provide for orderly and appropriate resolution of responsibility for client and patient care in the event that the employment ends or contractual relationship ends, with paramount consideration given to the welfare of the client or patient. What does that mean? We'll come back to it. So ethical practice requires reasonable planning to prevent harm. While we cannot predict or control the future, we can take steps to mitigate distress by arranging for the best contingency plans. A proactive approach aligns with our ethical commitment to do good. To understand the client's experience, I interviewed 15 therapists who lost their own therapist to sudden death. And these first-hand accounts provide a unique inside perspective from our peers on what it feels like, what's the impact of therapist loss. So some of the key findings were that the strength of the therapeutic bond influenced the depth of the reaction to the loss. Well, that makes sense. People talked with me about their own personal therapy histories and the attachment to their therapist and how it developed. And many of them described unfinished endings. The last session that was not known to be the final session at the time, only later. People talked about distress and uncertainty. There's anxiety in the silence before learning of the death. You're just kind of, where are they? What is happening? And the enduring impact. People shared memories, some from 40 years ago of a therapist's loss, in tears, some 10 years, some 2 months ago. The memories of the loss was vivid. So clients experience therapist loss as abrupt, disorienting, deeply emotional. Even therapists who've lost their therapists struggle with the unresolved loss. And that's with our perspective, kind of understanding that, we're only mortal as well, and we can't prevent everything. But again, think about, as we go through, how much you're willing to do to try and ensure that if something were to happen, you have a responsible contingency plan in place. So what is thoughtful preparation? It includes client notification protocols, practice executor planning, secure record management. All of those things can really help lessen the distress that your patient is going to be in if they find themselves in a situation of this kind of loss. Ethical practice means not leaving clients or the loved ones in uncertainty, fear, or grief without support. It's lining up the support. So what is a professional will and what is a practice executor? The professional will is a document. It's really a document for your personal executor, your next of kin, telling them what you want for your practice and telling them who you want to step in to fulfill those duties, because they inherit a practice and they don't know what to do with it. They don't know, family members, what needs to happen tomorrow, but a colleague that you have prepared and has the skills to step in is the person that you're going to appoint to fulfill those duties. So that will be a qualified practice executor, and you're going to give them in the will the detailed information and procedures for what they need to do. And the executor is that colleague who's agreed to take on those clinical responsibilities. And again, their job is to act with reasonable effort. This is, as I said before, a clinical role, not only administrative. When I have met with attorneys, I have been told, Robin, this is an administrative job. Your attorney can do it, a family member can do it, although that's not true in certain states. Certain states, let me just say, do have a legal stipulation of what it means to be a qualified person. And that is a clinician and in fact, a psychologist, if we're talking about psychology licensure. However, most states without that stipulation, I guess, technically, the attorneys are saying it doesn't need to be a clinician, but I don't know about you. I wouldn't want my family to have to step in. I also wouldn't necessarily trust them to step in a clinically oriented way, the way I would want my patients to be treated. And so need to think about who has the skill to be able to step in. Now, a couple points about the professional will. It does not supersede the professional's last will and testament. It also does not replace a professional's durable power of attorney for administration during the professional's lifetime. In fact, most professional wills are not even a legal document. It's not a contract unless both people sign it. It's a wish list. I can name anybody I want. I name, Barbie to be my professional executor. It doesn't make it so. A contract is an agreement where both people are promising something. Generally, the powers conferred to the practice executor are the ability to make decisions and take actions regarding client care and office records, medical records, along with the storage and disposal according to the law and our professional requirements. And typically, also conferred is the authority to pull in other people to help you administer the professional will. Everybody wants to avoid this, not only therapists, parents too. We need to do just a little more than talk about it. So I conducted a survey of about 120 therapists and asked them, what do you worry about in the event of your own death or incapacitation? And most people, most of you too, I would guess, worry about how your patients would be notified about your death. People worry about to whom patients are referred, the confidentiality of records, and to a lesser degree, notification of past patients about the transfer of records, providing paperwork so that people can get insurance reimbursement, collecting payment for the estate, lease and other business obligations, their office. What else do you worry about? Write it in the chat, if you would. Tell me what else you worry about. And what are the reasons that therapists give for making a professional will? Well, mostly they want to take care of patients. So most of you are here because you care about taking care of your patients. You also want to fulfill your ethical obligations. You want to take care of family and personal estate, and you want to protect your colleagues from the burden of having to step in and the tremendous job that it is to take on the dismantling of someone's practice. So without a will, patients might show up for their appointments and see a note on the door.
I'm sorry to jump in. To interrupt again, Robin. You mentioned about the chat. I just wanted to remind folks we have a chat and we have a Q&A. And for these webinars, the chat is disabled, but you can put the comments in the Q&A about to respond to Robin's question about other things that you're worried about. Sorry.
Okay. So without a will, patients might show up, they see a note on the door, they might be instructed to call a colleague of the therapist. They may or may not call. They may show up on a Zoom and wonder what's happening. They might, if they're given a referral by that colleague who they call, they might be given, all the patients might be given the same list of 3 therapists who don't have openings or wouldn't be appropriate or suitable. But that's technically, okay, technically they were given referrals. Is that the standard of care? Sometimes that has to happen. That's the best someone can do. But is that what we want for our patients? So an executor, in addition to protecting patients, also protects the family from having to field calls for patients, from patients. So one patient told me that he tracked down his therapist's wife because he wanted to know where the grave was. He had found out that he had died after the funeral had already happened, and he really wanted to visit the grave. The patient said he felt flattened out, and it took 6 years before he saw another therapist. So I can understand from the patient's point of view his longing and his desire to be there at the site of his beloved therapist's burial. But think about it from the family perspective, from your perspective. Do you want your family to be getting calls like this? Wouldn't it be a way of taking care of your family if there was a colleague who could help patients in this way? So in my survey, almost 70% of therapists do not have a professional will. What gets in the way? Well, denial of our own mortality, lack of knowledge. We don't know how to draft a legal document. We don't know who to ask. We don't know what is going to need to be done. And we don't want to impose on another. Here's a quote I like, succinct. Western culture is deeply embedded in a denial of death. People rarely speak about it, and there's a collective avoidance of anything that reminds us of our mortality. So, what is the impact of therapist death without thoughtful planning? The failure to anticipate client grief leads to lasting harm. Clients who are not notified by someone capable of understanding their grief and referral needs experience not only deep sadness, but also anger and betrayal. The person they turned to for help had dropped the ball in a big way. Lack of a clear and compassionate process left clients feeling disregarded or abandoned or even manipulated. So here are some examples. One therapist client had repeatedly asked her therapist if she was ill, picking up on how she appeared, and the therapist denied it many times over many months. Later, not long after a last appointment had been had, a couple days later, the client received a text from a mutual acquaintance saying, "Hey, did you hear who died?" That therapist. She attended the funeral, the client, and learned that her therapist had known she was dying, but had not told anyone. And she later received a formal letter from an assistant offering referrals and records, but weeks had gone by. The client said she felt gaslit and lied to, and ultimately viewed the therapist as being selfish for continuing to practice without putting in place some process to anticipate the ending of the work. So a client might understand, and in fact, these therapists that I spoke with did understand with empathy why a therapist might withhold personal details. You don't have to share everything with your patients, of course. But dishonesty or a complete omission can feel like a betrayal, and it damages the way they internalize the loss. Another client knew that her therapist was ill. They had worked their schedule around medical treatment. And the last contact was from the therapist saying, I'm entering hospice for a few days, but I'll be home soon. And though that was a puzzling email, the patient thought, okay. But a week later, the patient found out from her own husband that the therapist had died because his therapist told the husband to tell his wife. So this person felt really abandoned. She said either she knew and didn't tell me, or she was in denial. Either one is disappointing. The therapist lives on in her memory, she said, with love, but also with frustration about how she left me hanging. And the client wished that the therapist had been more honest about a prognosis, or at least acknowledged that there was some uncertainty. Wish there had been a clear plan to be notified when the therapist passed. And wishes that she had been given information about the funeral to have had the option to attend. So again, you don't owe patients your private information, but you need to consider them and the impact on them. What kinds of communication feel ethically responsible, clinically sound? How would you want clients to learn of your passing or of your incapacitation if there was an accident? Would you want them to have access to a memorial service or some kind of closure ritual? So what are best practices? Need an executor who can thoughtfully notify clients. You need to consider what you would want and provide detailed information, instructions about the kind of conversations you would want someone to have with your patients about your illness or condition. You yourself may want to have honest, even if boundaried, conversations with your patients. A plan for notification in case of death, access to referrals and records, recognizing that silence or avoidance or secrecy can leave lasting wounds. So when I interviewed these 15 therapists, one told me that they had received a call from a colleague of the therapist canceling the session, saying the therapist was in the hospital. This patient called the hospital every day, wanting to check on the therapist, and he recovered. Then the patient received a letter saying, due to doctor's orders, he needed to end the treatment. But the patient knew other people who were continuing in therapy with that therapist. So she felt very rejected. Soon after he died, and then the therapist's wife began billing the patient for sessions she had already paid for, adding insult to injury. So the patient said, my biggest fear was not death, but rejection. And this played out in multiple ways. So of the 15, 2 found out by text message, 2 received a call from the therapist's spouse, 3 were told by a colleague of the therapist in a sensitive manner. That is what we want. That's what we're going for. 1 was told, I have no one to recommend you to. One was given referrals. 1 got a phone call from an administrator who seemed overwhelmed and never called back. 5 were really angry. Good treatment suddenly turned into, feelings of betrayal and anger and disappointment. Only one of the 15 knows what happened to his medical records. So think about that. What happened to everybody else's records? Where are they? Who retained them? Who destroyed them? Were they gotten rid of in an ethically compliant manner, or was confidentiality breached? And how many of these 15 practicing therapists who lost their therapist do you think have their own professional will? 6. 6 have made their own professional will, even though they have been through this and know the loss. Denial is that powerful. So I'm going to leave it on this slide for a couple minutes while I tell you a story. But I want you to think about, what does reasonable mean and paramount consideration to the welfare of the patient mean? What do those things mean? Think about this as I tell you about another sudden termination of a long and fruitful therapy. So how would you feel if you were informed by text message that your therapist of 15 years had died? Does paramount consideration for patient welfare suggest that client well-being should be prioritized even when facing our own personal difficulties? I think it does. So in the case of someone I will call Ella and her therapist, Dr. Smith, this anecdote illustrates the emotional toll of inadequate planning, a deeply painful and avoidable sense of abandonment. So Ella, an early career psychologist, told me that her therapist, Dr. Smith, had seemed off, oddly argumentative, defensive, aggressive. They had a session that ended badly. At the next appointment, Dr. Smith did not show. Dr. Smith missed a couple of sessions and did not return Ella's phone calls. Ella began to despair. She felt rejected, and she thought, maybe she's given up on me. After 3 weeks of silence, Ella received an unclear text message about Dr. Smith's return to office being delayed. Another 3 weeks went by, and Ella received a text message from a friend saying, "I'm so sorry to hear. How are you doing?" Ella was bewildered, thought the message must have been sent by mistake, then learned that her beloved therapist had died the week before and the funeral had passed. So nearly 2 weeks later, a colleague finally reached out to explain that Dr. Smith had been diagnosed with a terminal cancer a few weeks earlier and refused to plan for her clients, was stoic. So there are major emotional and clinical consequences, shock and confusion. Ella had no idea what happened and initially assumed she had been abandoned. There's complicated grief. She struggled to integrate the loss because it felt like a betrayal rather than a closure. And there's guilt and anger. She felt conflicted about being upset at someone who had died. There also was loneliness in grief. She was unsure who could understand the magnitude of her loss. And she had difficulty honoring the therapeutic work because of the pain of the ending. She felt it damaged her view of the work. So looking back on her emotional growth over those 15 years, Ella said, if it had happened 5 to 7 years earlier, I would have been traumatized by the loss. By this time, it's incredibly sad and painful, but we had built a sturdy enough tree with branches with a strong trunk and roots so that the storm blew leaves off and branches off, but did not uproot the tree. It's really a testament to the power of therapy, the positive power, and then the pain that comes with an abrupt ending. So Ella had been crying as she told me this story, revealing she had not yet spoken about this loss, which was recent. And she felt that others wouldn't be able to understand the magnitude of her grief. Mourning for your therapist is not, a social uh, construct that everybody understands when you say you're grieving. So it's something often kept private. I believe Ella is listening today to this talk. So I want to thank you very much for sharing your story with all of us. What could have been done differently? Ella's experience raises some key ethical and clinical questions. If a therapist knows that they're facing a life-threatening illness, what is their responsibility to clients? What steps constitute a reasonable plan to prevent harm? How should clients be informed of a therapist's passing to allow for a proper closure? Would reasonable include a practice executor to be sure that the client was informed in a compassionate way, in a timely and direct manner, rather than in a cryptic or delayed message? And a plan that prepares for illness progression rather than avoiding it. So this is not about blaming people. We are only human and we are fallible as well. But it's about learning from these stories to try to shape professional standards. We have to consider what we would want our clients to experience in the event of an absence and take proactive steps. I think we also need to move beyond legal definitions of reasonable towards a more clinically informed and ethically minded approach with empathy at the core. So here's another plant picture because I think everybody needs to be repotted. Without some kind of care in place, one patient told me she felt all my history was lost. A psychology association told me they got calls from a landlord wondering what should they do with their therapist tenants' files. There's a real risk here for breach of confidentiality. People find out by text. They get called by the therapist's spouse or child. They never get called. They don't get a referral. They slip through the cracks. There could be this violation of confidentiality. There's certainly unprocessed grief, abandonment, rejection, rage, distrust of the profession. There could be a financial impact if people don't get the reimbursement documentation that they need. In one abrupt ending, someone I'll call Michelle knew that her therapist, Alan, was taking time off for a planned surgery. And she was shocked when a few weeks later she learned that there had been complications and Alan died. Michelle was called by a colleague who said Alan had left no professional will, and the colleague said, "I have no one to recommend you to." Michelle was devastated by the loss of this important support as she was in the middle of a major, difficult personal circumstance. And then she soon found that most therapists were not accepting new patients. And she was angry that Alan had not left a plan in place for continuity of care. And that anger made it difficult to eventually establish an alliance with a new therapist. Why now? It's only our 8th life. We are procrastinators. So now I am going to tell you about some of the experiences that I have had as a practice executor. And I'm going to take you through what an executor needs to do, what you're faced with, what you need to do. I think this is really important to understand before we get to the part that you're really here for today, which is to learn about planning your own will, I bet. But it's important to know what you're asking someone to do for you. It's important to think through how they're going to do that to inform what you instruct. So most of the examples I'm going to talk about come from my experience with the friend I mentioned at the beginning. I received a phone call, and I'm going to call her Dr. B. Dr. B said, "I'm in the hospital. They found a tumor. Can you cover?" Dr. B from that point forward was hospitalized, medicated, incapacitated, with pain, with coping with the terminal diagnosis, knowing she had a very short amount of time and needed to spend it on her personal affairs. But she really did want to reach out to her patients, and she provided this example of grace and generosity that kind of blew my mind at the time. I remember saying to her, she was so thoughtful and devoted about her patients' needs. Like, come on, really? I don't think other people are thinking about their patients in this way in your situation. And she said, well, I don't know how to do it any other way. And that was who she was. But I was able to learn a great deal from who she was and her thoughtfulness about the impact. So I am mostly going to talk about Dr. B. There was another experience when another dear colleague had an incapacitation, and it was unclear what was going to happen and needed to step in a different way without the benefit of having knowledge from the therapist about their preferences, which I was able to have for at least a very short time and in some few conversations with Dr. B before she passed away. And another experience was not as a practice executor, but a teenage client of mine many years ago. His father had been telling me about his own therapist, who was incredibly important to him and helping him through a bitter divorce. And shortly after he told me this, I saw an obituary for that therapist, and I didn't know if this father knew. So I called him and I told him I was not calling about his child. I didn't want him to be concerned about that, but I asked him to call me from somewhere private. And I told him that his therapist had died, and he was devastated, crying. He said he had gone to his appointment. He had seen a note on the door. The note had said to call another psychologist, a name he didn't know. And he just didn't, because he thought, she must have had an emergency. I'll come again next week. And he was devastated and also quite grateful to have been told. And it was, a foundational experience for me about the importance of, treating people the way we would, want a loved one to hear of, terrible news. So guidelines and considerations for professional practice executors. I'm going to talk about 3 phases. The first is the immediate triage of patients' needs, current patients. They are the focus at first. And then there's the business of the practice. And then there's the dismantling of the practice. These are more of the administrative tasks that many people consider when you think about this job. So most of the models most of the examples as I go through are based in this one-to-one model where a therapist says, as Dr. B and I did so long ago, I'll do it for you. You do it for me? Sure. And we make that very casual promise without much information or much thought about what that would entail, and certainly never expecting that we would need to step in for one another. So you will see as we go some of the problems that come up in this kind of arrangement, and we'll talk about alternatives later. So the first phase is this immediate action, the people who are going to be knocking on the door tomorrow and the next day and the day after that. And they, as patients, have their presenting problems that they need help dealing with. And now they're going to be given the notice of, a really devastating loss that they also need to be supported in processing. So they need coverage too. In this situation, let's say, first of all, the situation I was in with Dr. B, where there is an incapacitation, but there is not a sudden, complete absence of the therapist, at least for the practice executor. So in this case, I was able to speak with Dr. B. She gave me thumbnail sketches about each patient. She told me what she wanted for each patient. She gave suggestions for referrals for each patient. These are the kinds of, amazing insights that you often don't have when you step in to help someone who's gone through a tragic situation. You have to just figure it out. But in having Dr. B instruct me, again, that really just opened my eyes to how thoughtful and planful we could be if given the opportunity. So the first thing you would need to do in this situation is make sure the medical records are secure. You don't have to do anything about them. You want to make sure they're locked in a drawer in a locked room or locked electronically, password protected. I wanted to say a minute ago, is if you're in a situation like I was with Dr. B, you want to ask right at the start, how involved do you want to be? Do you have the energy or resources? If not, that's fine. I will figure it out. But if you do, okay. Do you want to contact people yourself? Dr. B insisted she really wanted to, but after she made 2 or 3 of those calls, she realized that it was emotionally draining and she didn't have the presence of mind or capacity to do this. And I was really very sad for her. It was really hard for her to step back and to have me do that. Hard for her to acknowledge that she couldn't complete these terminations for self. So you would want to set aside time and emotional energy to make calls to patients so that you have the space to be present and available. These are not quick calls. These are not robocalls. These are really empathic calls. And one of the first things that you want to do as well is to change the voicemail or the email or the website so that more people either interested in beginning therapy or trying to reach the therapist are not leaving messages that you will then have to return. You want to change those points of contact to indicate, and there's a variety of ways you might do this, but something along the lines of Dr. B is on leave from her practice in the event of an emergency, or if you are looking for your medical records, please reach out to Robin Miller. You may more succinctly say the practice of Dr. B has been closed. Please contact Dr. Miller for any information. You want to get a hold of patient contact information as quickly as possible. You want to find the schedule. Like I said, you want to start in order. These calls take a long time. These are slow, painful calls. And so you want to let the people scheduled the soonest know the soonest. And you want to think about referrals, both long-term and crisis referrals, before you start making these calls. So I reached out to just a handful of close colleagues before I made these calls to find out who would be willing to be a point of contact for as crisis coverage for anyone who needed that, and who might have openings to take on any of these patients for ongoing therapy, which wasn't, something that needed to be figured out this second. But if I didn't have those names, then that meant I would be calling people back, which often happened, to, say, I'm going to locate the appropriate referrals and I will get back to you. Dr. B, as I said, was really quite selfless. So some of the things she instructed me on was, she said, okay, regarding this patient who's a college student, don't call them yet until next weekend, because they're going to be visiting their family next weekend, and I want them to have the support of their family around when you tell them. She said another person who was a paranoid patient, she said, don't call that patient, call the patient's father. She had a release for the father. Call the father and have him tell his son, so that it's not a disembodied stranger on the phone telling this tragic news, but that he would be able to take it in better from someone that he knew, from his own father. Another person, she told me that this lower functioning person did a lot better when the person's partner was part of a joint call, and she had had that kind of contact before. So she told me to coordinate a time when both of them could get on the phone with me, so the partner could be there to support that patient when I told her the news. There was one patient who was dealing with her own health crisis, and Dr. B was afraid that hearing that Dr. B had a terminal illness and was dying, which was Dr. B's preference for what I told people. She wanted them to know kind of the hard, blunt truth. She didn't want anybody to be, hoping against hope, but she wanted them to accept the finality. So she worried that this patient who was dealing with their own health crisis, that they would perhaps, be compromised, physically compromised by the stress of hearing this news. And she didn't want me to tell that person until they were in a more stable place, which was going to be a couple of weeks away. And so with that person, I said, first, she's ill and needs to cancel her appointment with you. I will let you know, if when she's able to reschedule. 2 weeks later, give a little more information. She is hospitalized. They're trying to figure out what's going on. A little bit later, she's been diagnosed with cancer. And then ultimately, when she had reached that time that Dr. B felt would be a more stable place, gave her that hard, cold truth of this terminal cancer and of Dr. B's death at that point. So I want to say something about group practice owners. It's important for you to think about, if you have a person on your staff who you want to step up to be the assistant or associate who will run the practice in the short run. Someone who knows how to access billing, someone who could offer payroll to your staff, because you also need to think about, if you weren't there, how will people get paid? What will happen for your staff members tomorrow? Who's going to notify those staff members? And you want someone inside who can step up and knows how to do that to keep things stable for the immediate future, because then your estate will need to decide what to do with the practice. And you may want to have that conversation and leave those instructions with your estate. Do you want someone to try to sell your practice? Do you want to see if your staff members want to buy it? Do you want everyone to take their own patients and their own records and go out on their own, and the practice is dismantled? Think about those pieces. And when you are going to be interfacing with patients, your colleagues' patients, you don't know these people, you don't know what their presenting issues are, or how, what you're going to be met with. So you do need to have in mind bringing your best therapy self to the job. And what is your goal? We are not serving as the therapist. I want to make that clear. The practice executor is not taking on all of these patients yourself. You are shepherding them to the right place. So what are you doing? What are you trying to do when you're reaching out to them, therapeutically, not as the therapist, but with a clinical mindset? It seemed to me like a big part of my job was trying to protect the way the patient internalized their relationship with the therapist. So in the examples that I gave before, with people who were not informed, they sometimes felt like their beloved therapist, all of a sudden they thought was, irresponsible, and they were so angry. And, we can talk about all the ways that that was protecting them from grief and from the devastating loss. But I think legitimately, when we rely on a provider to know how to put in place the care that we need, and then all of a sudden there's no care, there's a sense of betrayal and anger. So I wanted to protect that, not only for Dr. B's sake, and I think not as much as I would want that for her, it wasn't really about that. It was for the patient's sake, to know that Dr. B truly cared about them in a way that was consistent with their experience of Dr. B throughout the treatment. So I wanted to communicate that Dr. B had put a plan in place. Dr. B has wanted me to reach out to tell you this upsetting news. Dr. B wishes she could tell you herself. And it doesn't matter your therapeutic orientation. You're going to approach this just as a human being, knowing you're about to tell someone, really painful news. And you want to consider the clinical issues that are likely to come up: abandonment, loss, trust issues, feeling rejected, triggering trauma. We don't know, as we tell someone this, what other losses that they have suffered. Anxiety, existential fears, anger, empathy, the desire to help. Some people really wanted to, can I drop off food at her house? Would it be okay if I sent her a card? Could I, excuse me. Patients, patients care about the therapist too. And be aware of the countertransference. your own grief as you're making these calls? Does that manifest in a depressive stance? Are you flattened and blank when you really need to be able to be more of a holding environment for this person that you're calling? Are you over functioning because you're grandiose about how you're going to save them from pain of this loss? Are you angry yourself? And is that going to be put onto the patient? You're going to be angry and annoyed at them for their needs. Kind of look at what is stirred up in you. One of the 15 therapists that I had interviewed had a piece of advice and said, make sure the person you are referring the patient to can tolerate the loss. That person said he had gone to a new therapist and was talking about the loss of his therapist. And that new therapist said, but you're working with me now. That even therapists may not understand the degree of loss. So as I've said, I called these terminations by proxy. I was doing the termination on behalf of Dr. B in this weird way on the phone, totally inadequate, but held that in mind as part of the intention is to do what I could in that circumstance. So you want to set aside time for these calls. If necessary, leave a message to call you back, but do not leave any information in a message about what has happened. Allow for the patient's reaction and respond honestly. This is a time for empathic murmuring, leaning in, waiting, letting them react. You do want to provide them with crisis coverage if needed. As I said, you might have to call back later to give referrals. And depending if you are the practice executor who is able to know the wishes of the therapist regarding how much information to tell them, or would they want patients to be welcome at a memorial service, you may need to call the patients back multiple times to provide more information as it came along. If you say you're going to call back, give a time frame and keep your word. If you say, I will call you back next week with referrals, do it. If it's clinically indicated, consider an in-person meeting. Here's a script that after doing a number of these calls, I sort of developed to help me. I'm the psychologist covering for Dr. B's practice. Are you in a quiet place where you can speak privately? Are there supports available to you? I have upsetting news to share with you. Dr. B wishes she could tell you herself, but she is not able to. She has been diagnosed with terminal cancer. She is very ill and not able to be available to her patients anymore. And then pause and see what comes up. You're not going to grieve with them. You're not going to overpromise. You're just going to be reacting in a deeply human way. So some people said to me, I'm so grateful. Please tell her she's been a wonderfully positive force in my life. I'm shocked. Dr. B was amazingly stabilizing for me. I could always count on coming in and getting grounded. Someone else said, Dr. B has been there for me more than anyone ever was when I was a kid. Dr. B taught me emotions, literally. She taught me the words. That patient had been treated for, in part, pain management. And that patient was really concerned about how much pain Dr. B was in. She wanted to know. And she wanted to help. And she wanted me to ask Dr. B if the patient could help her get marijuana for medical purposes at a time and place where that was not legal, which I declined. Another patient said, "Oh, tell Dr. B I will be okay. Tell her not to worry about me." And then 2 hours later, she showed up at my office with a letter for Dr. B that she really wanted to be passed on so that Dr. B would know how much she had meant to the patient. And the patient was really worried that Dr. B would die before she had time to tell her that. And that patient actually texted Dr. B, despite asking me if they could. And I said no. So again, even as the practice executor, we can't control everything, but we can do our best to try to guide patients as to, what the therapist wants. There are also traumatic reactions. One patient who I informed sent me an email later saying, "I was very hurt by your call. I have decided I will not seek another therapist. What a waste of a decade spilling my guts only to be screwed over by the one person I trusted." You have to remember that, people are in therapy dealing with something, and the kind of issues that they're dealing with are going to inform the way that they respond to this news. This person later sent me an email apologizing, saying, how devastated they were to have heard this news. You want to document that you spoke to the person, document how they responded, document who you referred them to. And you can keep that in your own file, or you can put that in the patient's file from the therapist. So obviously, when you are doing this for someone that you are close to, it's devastating. This is in part why I've come to believe that it's not best practice to rely on a friend or close colleague who will be grieving at the same time. It's an incredibly overwhelming and painful experience. There's the pressure of time. Things need to happen quickly, but you only have so much time in which, I had needed to do my own, grief process, and time to say goodbye was taken up by all the duties of the practice. There's tremendous desire to help. So in many ways, it was something I felt really grateful to be able to do, to step in and do something. We all want to do something. That's a lot better than making a casserole, to be able to help in this way. But there were tremendous feelings of responsibility and resentment and the stress of a full caseload on top of my own full-time practice and caseload and family obligations and all of this that needed to happen all at once. So I have heard of some practice executors who needed to take a month off from their own practice in order to help take apart the practice of the person that they were practice executor for. It's quite overwhelming. And then there's also a parallel process between the patient and the executor. There's shock and grief and uncertainty and accepting the finality, all these things that I was kind of reeling with at the same time as the patients who I was calling to notify. So here's my plant, ready and needing a new pot. So phase 2, once current patients are taken care of, we can move into the financial aspects of the practice. And you need to decide ahead of time, preferably, if you want your personal executor representative to take care of some of these business or financial matters, or if you want the practice executor to do that. It really depends on the therapist on the practice executor, how much you're willing to do, and on the family of the therapist who's passed away, how involved do they want you to be? And of course, that's an individual decision. But what you might do is you might complete billing in order to collect outstanding payment owed to the practice. You might want to close patients' accounts. That way you help the family who now has, unexpectedly lost an income. You can at least help get final payments. You complete paperwork that people need for insurance reimbursement. For things beyond the scope of the practice, you might want to consider a limited power of attorney, which would grant authority to handle specific financial matters, like closing a bank account or dissolving an LLC or terminating a lease. Those are things that require an authority, appointed authority beyond kind of these clinical and practice matters. So once that is taken care of, then we move into the closing of the practice. The final work really starts with medical records and then assisting with any of the practical or administrative aspects of closure. So the first thing that needs to happen is to determine the state-specific requirements. What is the retention period in that jurisdiction? Do you have to notify patients before their records are transferred to another location or the custody of someone else? Do you need to register a professional will or register a practice executor? In some states, yes, to some, and no to others. APA suggests retaining records for 7 years. If you're practicing under SIPAC, you follow the regulations in the location where the patient is, if they're more stringent than in your own state. For Medicare, it's 5 years. Medicare managed care plans, it's 10 years retention. For HIPAA, it's 6 years for the documentation that HIPAA oversees, like patient authorization for disclosure of protected health information. If you keep that in the medical record, then you need to comply with the relevant state law for medical records. It can't be less than 6 years, but it would have to be as long as is required. So you do have amazing resources here with the trust, the Advocate 800 program, and risk management consultations to be sure that you understand your particular responsibilities. So that is part of the legwork that you need to do in making your own will, but it's also part of the responsibility that the practice executor has to figure out what your obligations are. And here you don't need to, really know this. I just want you to see visually how each state has a different set of regulations. So some have no required professional will responsibilities written into law, but you would still be under the APA ethics code. Some states have the APA ethics code written in to their regulations, so then it is a requirement. Some states have their own regulations, Oregon being one of the most conscientious regarding professional wills. You must name a qualified person. So in Oregon, it does have to be a psychologist licensed in Oregon who is appointed and reported, the name is reported to the board. That person will be responsible for your records in this situation. In some places, you have to notify publicly either a notice in the newspaper for a period of time or a letter to all patients within some period of time. For Virginia, any patient who's been seen in the past 2 years needs to receive a letter saying that their records are going to be transferred to someone else's custody before the records are transferred. So you really need to to look at what the law is. And of course, different states have different retention periods. And then closing the practice. You need to continue to be available. Records may get subpoenaed. Former patients may want referrals in a year or two. Patients may still be, reaching out, looking to begin therapy with that therapist, only to be, notified that their practice is closed. One of the things you want to do is keep up phone and website with that message that I had said earlier, directing them to the practice executor so that people in search of their records or in search of that therapist will know where to go. You do want to close social media accounts. And you might, as the practice executor, you might want to help the family with these practice administrative matters. By ending auto payment, you might want to close down their Psychology Today and close down the EHR, and you may want to be able to get into their email accounts, all the things that might don't need to continue to be paid on a regular basis. The practice executor can step in and cancel those accounts. You may need a copy of the death certificate as proof. For some, the professional will is enough. You want to notify professional organizations, licensing boards, your malpractice insurance, who can add a tail after you close. This one's sort of a funny one, maybe a unique one to my circumstance, but when I was in Dr. B's office getting the records, because we had paper records at this pre-coded time, and I was loading banker boxes of records to my car to take for safekeeping, I saw in her office all kinds of little artsy kinds of objects that I just knew were patient gifts. And I did not know what to do with them, but it felt wrong to leave them. I sort of felt like I had a responsibility, as with any other clinical material, to take those. So I took them and stored them with the medical records. And a couple months later, I got a call from a woman who said she had been a very long time patient of Dr. B, but had ended her care some time back. But she had heard that Dr. B died, and she wanted to know what happened to all of the gifts that she had made Dr. B. She said I had given her these gifts because I wanted her to hold on to me, but now I want them back so that I can hold on to her. And I was able to tell her, I have those gifts and I will send them back to you. And I did. And it was, a very meaningful connection with that patient. You may want to assist the family with packing. You may want to help with a lease. The estate is probably on the hook for the length of that lease, unless they can sort of not only find someone else to take it over, but possibly negotiate to be released. Learning from this experience in my next lease that I negotiated, I did have my landlord put in a clause that if something were to happen to me, an incapacitation or a death, within 90 days, my estate would be released from that lease. Just as a way of wanting them to be protected rather than on the hook. Oh, sorry, one more here. So you also want to destroy the records, any records that are outside of the retention period, and you want to keep a log of whose records were destroyed and on what day. So this is a lot, right? So how do you use all of this to determine what is going to be best for you and your practice? So you need to think about, what is your directive? What do you want? How do you enable someone to administer your directive? What do they need to get it done? And whom to ask? What are your options? How do you handle this? So how do you want people notified? I think by phone is better than by letter if we're talking about current patients. You decide what you think is best. You want to list some referral suggestions. Who do you know who might be a good fit for these patients? They might not. So how is that person going to find additional referrals when, I don't know about you, but where I live, people are having a hard time finding a therapist with one opening. Forget about, as the psych executor, you need to find openings for 30 people tomorrow. It's challenging. So try and think about who's going to do that. What are your personal boundaries regarding what kind of information you want shared with patients? Would you want them told it's a medical condition, or you were in an accident? Or would you want them told the details? And of course, there's not a right answer. It's just a huge variety of your preferences. Some people like to write out a goodbye letter that you would want your executor to distribute to patients, something along the lines of, if you're receiving this letter, um, I have had an unexpected tragedy, and I am no longer able to be available. And I want to let you know that I have valued my work, and, going on to say whatever it is that you might want to say, and you can personalize that ahead of time. Or it's something generic then that you're instructing your executor to send out after the notifications have already been done, because again, I think that is important to be done immediately and, personally. The referral suggestions. Do you want to offer in-person sessions? Some people say my estate will cover the cost of that. So your estate might pay your colleague rather than having patients pay. What are your expectations regarding retaining and transferring records? How do you want the financial aspects of the practice handled? Compensation for the executor. So a lot of people are writing into their agreements with a colleague something like, my estate will pay you your hourly rate for the time you spend fulfilling these executor duties. Which sounds fine when you think it's only 2 or 3 hours of work. But as you can hear from what I'm telling you, this is 40 hours of work for a practice that sees 20 patients a week. So you do need to think about the significance of the bill that your estate would receive unexpectedly. It could be $10,000 or $15,000 if you're paying a colleague their hourly rate to spend, all this time taking care of your practice. Other people handle it by, agreeing to a flat fee or a nominal fee or a donation to charity, or the executor may decline payment, all kinds of arrangements. If you have a testing practice, you want to think about who, if you are mid-evaluation, who is going to finish it? Who is going to interpret your data and write the report? I have had some folks tell me no one could interpret the data or write a report but me. So they have suggested and decided on their own, which, I think is a nice idea, that their estate would simply refund any money already collected for that testing protocol so that the patient then has the money to go and seek services elsewhere. An idea. Again, group practice, how you want that handled along the lines of what I mentioned earlier, naming someone who would be able to step up temporarily. Do you have supervisees? How will they be notified? Who else needs to be told? And your authority to act. You may want to consider a business associate agreement that covers us for HIPAA. You may want to, as I mentioned before, consider a limited power of attorney. So then how do we enable people to do this for us? What do they need? Well, you want a contract. You want to know that someone really is truly agreeing to do this, not just that you wish that they would, but that they will. And what if they're traveling, or what if they're dealing with their own crisis? You want to name an alternate as well. You need to provide detailed information regarding access to your patient list, your contact information, calendar, office, files, computer programs, electronic notes, voicemail, email, passwords for everything. And as you know, passwords change often. Rather than having to remember to go and update those passwords all the time on some list that you keep somewhere that also may not be really protected, you may want to use a password manager and designate the practice executor as the emergency access contact so that they would be able to get access to your current practice-related passwords. And also you want to solve for the two-factor authentication that we get all the time when you log in. We're sending an email to you with a code that you need to enter to get access, or I'm texting you a code. Who's going to get that and be able to give it to the executor so that they can actually access the programs that they need? You want to provide copies of your professional will to your executor, personal and practice both, your attorney. Some insurance, liability insurance companies want that on hand. You want to amend your consent to treatment form to say, I have made arrangements in the event of an incapacitation or my death for a colleague or for a service to contact you and take responsibility for the confidentiality of your records. You want to leave funds for compensating the executor if you've decided to do that so that it's not a burden on your estate. And you want to remember to update your will periodically. So you're going to get your hands dirty, repotting. So the traditional model, mostly what we've been talking about, a one-to-one colleague agreement. Who do you ask? Well, in the days where we all had paper records and in-person practices, it needed to be someone who was nearby who could access your office and get your paper calendar and your records. And now that is not a requirement. Even people who have paper records, there are ways to digitize those files ahead of time or at that time to provide electronic storage as an option. But you do want to think about, when you're thinking, who do you want to ask? What's a good fit? What's going to give you peace of mind that the person will really be able to do what you're asking of them? How close are you? There are pros and cons to being close. As the therapist making the will, I think that provides a comfort. Understandably, you want to say, oh, someone I'm close to would be doing this for me. But it's not necessarily in the best interest of your colleague who would be doing it, or of your patients who need a certain kind of effective assistance, with referrals, with follow-up. They don't need the person who's calling them to be very close to you. They need someone who's going to be able to attend to their needs. So is it, a hindrance for it to be someone close to you? Often, and quite a burden it can be. But if you choose that, what are the personality factors? How do you relate to each other? How intimate and open? What's the need for control, dependency, trust? You're sharing really intimate things with this person, intimate access, not only your patients, but the inner workings. And so how are they going to relate to you on that? You want to consider the therapist's family style, because some may say, no, I don't want this colleague who I don't know in our, financial matters. So their preferences influence things, and so do cultural factors. We all bring to the table our traditions and expectations or and attitudes about death, and you want to bring that to the fore so that you know what to expect on both sides. The therapist whose family may have a certain way of wanting to handle things, and the practice executor who brings their own thought. And realistically, how will they have the time and resources to complete all the urgent and time-consuming tasks? So this is often done using a template from the internet or having an attorney create a will for you. That typically costs $1,500 to $3,000 to have an attorney make a piece of paper that is legally um, verified, but it doesn't actually cover the doing of the job. That is something else. So you still need to find out who is going to do this and how are they going to do that. A couple colleagues that I've talked to have, said they've needed to come into the office of someone who has passed away and scramble to figure out what to do. Families have had to dispose of 40 years worth of records that are kept in the basement. Think about the burden that you are leaving behind and how hard would it be? And also, do those people have the knowledge to be able to do them in an appropriate and responsible manner? And how much assistance would be needed from your own grieving loved ones? Do you want them called all the time? Where's this? Where's that? How do I get the key? Do you know about this? Or do you want that person to just have the information that they would need? So lessons learned. I'm just going to give you a minute to read through. So let's talk about alternatives. Another way is with a cooperative group agreement, where you share the responsibility among a group of colleagues. You want to recruit a peer network with similar therapeutic style who everyone agrees to assist one another. The benefit being there's a supportive group. You're not relying on any one person. It's a shared burden, diffusion of that responsibility. You want to talk about each therapist's unique needs. One psychologist that I have worked with is in a peer supervision group, and they each went to each person's office to look at where the files are kept and where they put the key. And, I think they were overwhelmed by that, the practicalities involved. You want to create an agreement and assign responsibilities. So who's handling notification? Who's finding referrals? Who's making those phone calls? Who's writing letters for notification of record transfer? Who's completing billing? Who's retaining the records? Who's interacting with the family? Who's handling administrative practice matters? Who has the passwords? All of these things need to be figured out ahead of time. And one of the risks is that there's such a diffusion of responsibility and things may fall through the cracks, people thinking the other person's taking care of it. You want to figure out how are they going to be communicating to avoid misunderstandings. You want to consider confidentiality violation risks. You don't know, whether some of your colleagues know your patients personally, maybe socially. So, what are the risks of overlap? Ann Steiner has been doing this work for a long time, and she offers some trainings, the therapist professional will training, and she recommends an emergency resource team of trusted colleagues, and she calls the bridge therapist the person who serves as the main contact and the coordinator of everybody else. And there is her website that you can check out. And then there's the professional executor service, which is what I tried to create as a solution to each of these problems. So you can hire a service who has expertise in creating a comprehensive attorney-reviewed will. You can contract with a professional, a clinician, to serve as your practice executor, ensuring that the person who will be reaching out to your patients has expertise in grief, in referral making, and in the business aspects. You can protect your patients with a fail-safe plan, no leaving it to chance. You can trust that the ethics of your practice and the laws of your jurisdiction will be upheld. You can save time and stress by outsourcing tasks beyond your scope of practice to people who do know how to do these things. You can control costs so that you pay yearly and protect your estate from unexpected financial liabilities. So the way that we have structured our service is that you pay kind of a membership fee to keep us on retainer, essentially ready to step in at any time. Like car insurance, you never think you're going to get in an accident, but just in case, you're covered. And that's how this works as well, so that there are no follow-up fees for the clinical hours spent contacting patients, helping with referrals, taking the records, record retention. So you know that your estate will not get a big bill. And you spare your family and colleagues from the burden. And this is where you can find us. It's TheraClosure, and worked hard to try to come up with the solutions to all of these issues in a modern and comprehensive way to make it easier, so that instead of 70% of therapists don't have a will, hopefully people can get it done, cross it off your list, stop being burdened by it, and just know that you've done it and you can practice, hopefully for a long time, in good health and in good faith, and know that you have done your due diligence. So with due diligence, patients feel cared for, they feel respected, they feel supported, they feel like they got good treatment, even if they're sad. The positive transference can be intact. The internalization of a good self-object can remain. They can be able to continue therapy with hope. And your family and colleagues can be protected from burden and financial and legal risk. So one of those 15 therapists who lost their therapist told me that they knew their therapist had been ill, but she seemed to be recovering. And then she got a call from the therapist's colleague informing her that the therapist had suddenly died. This therapist client said the colleague was so compassionate, offered support, offered referrals. The patient felt shock. She felt really sad, but she felt that it was handled beautifully. Two clients spoke with gratitude that despite the tragic circumstances of the abrupt loss, they really felt cared for by a plan that considered them and provided for timely, personalized notifications about the death. They felt grateful when they got calls from attuned covering therapists who could tell them something about what had happened and who could offer to meet with them or connect them with another therapist. When the patient surmised that the therapist had been organized and prepared, that's in quotes, they held the therapist in high esteem and felt good about the treatment despite the loss. Some therapists had the opportunity, the rare and lucky opportunity to actually say goodbye, either by phone or by one final session. And that was really healing for people. If that possibility exists, they thought it was really kind. It was really generous. It made a big difference. One patient who got to say goodbye to her therapist said, now I know better how to face death myself. So if possible, but of course, not always possible. The patient really wants the opportunity to express appreciation and value for the connection. So as I come to a close in just a minute, I'm going to tell you one more story that is really about the testament to the power of therapy, which is what all these stories are about the bond that we create. So he loved me, said a retired analyst that I'll call Steve. And he was speaking about his own analyst, Frank, from a long time ago. He's telling me this story from long ago. He recalled that they were nearing termination, and after Frank's annual August vacation, they met and resumed work for 1 week before Steve then got a phone call. Frank told him he had been diagnosed with a terminal illness and needed to stop working to focus on his own situation. Steve respected that Frank thought it best to terminate rather than to continue the therapy to avoid making it about Frank's illness rather than Steve's needs. Steve understood that. And Frank encouraged Steve to see someone about what was happening. So before long, Steve learned by notice on a professional listserv that Frank had died, and he went to his memorial. He listened to other people speak about the man, not only the therapist that Steve had known, but the man. And Steve felt that he had really known Frank authentically as a very real human being. He said, "This was more difficult than the loss of my parents. Who knows you better than someone you've been talking to intimately for 8 years? I had expectations he would be there for me. I was devastated and overwhelmed." Tearful as he shared this story, Steve wished that he had been able to see Frank in person one last time. In making his own emergency plans for his own therapy clients, Steve said he believes the important thing is that their suffering is minimized and not added to by negligence, so to speak. So that is what I want to leave you with today. Minimize the suffering by doing what you can do. Find your own way. Any of these ways work. And here, get it done. A reference list, a checklist, and some templates for example you can see, not for legal advice. So thank you very much for your attention.
Thank you, Robin. What a great talk. Really comprehensive. We had a lot of really interesting questions. I know we won't get to them all. I wanted to just start by pointing out some of the comments people made when you invited them to ask what are they concerned about. Just a few things, averting a malpractice claim, of course. I'm being concerned my clients might find out about my death in the newspaper. Being concerned, how will clients know how specifically I knew and cared for them? And I think you offered some great suggestions about, leaving a note or a message for them with your executor. um, being worried about notifications about their funeral, if there is one, if they feel the need to grieve in a structured setting, worrying about teenage clients with a history of suicidality. How would they respond in the event of their death, particularly those who find that therapy, the only or the most meaningful outlet they have at the moment. I did want to just tackle one question at the top because it came up about under what circumstances would the practice executor need to speak to the trust or their insurer, and what would need to happen. I just wanted to. You mentioned about insurance tails. I just wanted to point out for the trust, as those of you know, we offer a free extended reporting period or tail in the event of a death or retirement of our policyholders. And that's an important benefit. It can certainly be a great help for the executor and a comfort for the therapist. So same thing can be said for when someone retires, and there's no need to bank your professional will with the trust. There's no need to provide us a copy. But let me give you some of the other questions that came up. One was, do we need to include information about a practice executor in the informed consent? And should the patients be told whom the executor is and given their contact information?
That's really individual. There is no hard and fast rule on this. There are some people like Tom Gutile is a psychiatrist who writes on ethics and has worked with Ken Pope, who says he doesn't even like it to be in the informed consent because he thinks it sets a bad precedent, right, when you're meeting your patients to be talking about your potential death. As psychologists, we tend to err on the side of informed consent, but I think you can do that in a general sort of way, unless maybe there's a real concern for privacy issue of maybe a public person who does want to make sure they don't know the person that you would, be appointing.
Okay, great. Thank you. Another question you shared about the experience of helping an impaired or a therapist who's dealing with a significant illness and very impaired, and them being helpful, of course. What if you have a colleague who you have that relationship with and they're kind of in denial about the severity of their impairment, maybe asking you to help, but kind of ties your hands in terms of the support that you need to step in and provide for them?
Yeah, that's a hard one. I mean, I get that question a lot about, maybe people who are starting to experience some dementia or cognitive decline, and how do you help a colleague kind of know that it may be time to hand over the responsibilities to someone else or close their practice. And I don't have a good answer for that.
Yeah, yeah. Um, what about special guidance or thoughts about notifying child clients? How would you just notify parents and let them handle it, or would you bring in the child for a session and the talk?
Yeah, well, again, I think that depends on the circumstance and the planning. Certainly, you're going to call the parents, and I would say about the question about teenagers as well. If the parents are going to be a support, and maybe that is something you want to document for this patient, do not call parents, call the patient directly. For this patient, teenage patient, um, call the patient directly. Sorry, I think I mixed my words.
Mhm.
Uh, with a child, certainly you're going to tell the parents if as the executor, you have the capacity, and if you as the person who wrote the will want to pay them to do that and want to, make sure you appoint someone who could invite the family in to tell them in person. That seems lovely, but remember, time is of the essence. They're going to hear about it some other way. And so I think reaching out and notifying the parent and letting them begin that process is probably what would happen most of the time, unless there's a special circumstance.
Um, Another question came up about someone who's already retired, but and have not been seeing patients like for 4 years. They're concerned about notification of past patients for transfer of records. Um, is a practice executor still needed in that case? It sounds like as long as there are records, there might be. Would you agree?
People handle that differently. There are these big medical warehouses that you can pay to keep your physical files, and they would be the point of reference, and they would transfer, copy the file and send it to someone if needed. So that is an option. But if you want a clinician to be interacting with a patient, even, 5 years later regarding, referrals or anything that came up in the meantime, then yes, you would need a practice executor to be available to do that. And as far as notifying past, there are places where the ethics and the law and the clinical judgment butt up against each other in a way that isn't very smooth, and you have to make your own choice. Some people say, like, why would I want someone who I haven't seen in 5 years to get a letter saying their records are being transferred to someone else? Isn't that going to be more upsetting to
Mhm.
them out of the blue? But in some states, that's the law. So these aren't easy.
Yeah, yeah. Well, and another records question, and I guess, what is your experience with EHRs? I mean, is that, I would think, a subscription that needs to be extended until the patient files are downloaded?
Yeah, so EHRs make it actually a lot easier on your practice executor to handle this. It can often find your schedule and your contact information and your records all in one place, and they can assist with the billing pretty easily, and it does make it easy. The practice executor has a couple choices. You can, in most EHRs, be able to retrieve and download as a PDF all of the files, and then the practice executor would need to store them in their own password protected vault, and maintain them. Or some of the practice executors do have like a follow-up, I forget what they call it, legacy service or something, where you pay like $5 a month and you can retain the records within their system. But what we do is download and take custody ourselves and then close down the EHR. So that's not some continued fee.
Great suggestion. I'm really glad you talked about alternative two, kind of the group approach, because a lot of people had questions about that. Hey, do I have to put this all on one person? I wanted to just share a positive comment someone made. I appreciate this talk so very much. A few years ago, several colleagues and I who work with similar types of clients started meeting twice a year to have a professional will collective, where we created our documents and set up systems to make sure someone would be able to support each of us when needed. It has been a huge breath of fresh air when hearing these heartbreaking stories. And of course, there's your alternative. Not everyone has a great support group like that willing to do that. And that's, of course, their closure using a professional executor.